I have the pleasure of announcing our speaker today. This is our third educational opportunity for our MyTVT group. It's very exciting. We had one site ask if anyone was doing nurse-led sedation in the state, and this led to conversation and interest, and us asking Joan Michaels to help us find someone to talk to us about nurse-led sedation. And she very quickly and helpfully gave us Dr. Patricia Keegan, who's going to speak to us today. Dr. Keegan is from Emory Heart and Vascular. She's their Director of Strategic and Programmatic Initiatives and also their Clinical and Operations Lead. If you look up her name, she's in multiple publications with both TAVR and mitral procedural publications and alternative access, minimalistic approach, readmissions, lots of procedural variable type publications. And so I've also indirectly worked with Patricia on Joan Michaels, some of her work groups, and she always goes to Dr. Keegan for advice and help for version 3, for how to get follow-ups, or what about readmissions, all this stuff. She recommends her a lot. So I really appreciate your time. I really appreciate your insight and helping to teach us all about nurse-led sedation. Thank you very much. And go ahead, Tricia.
Oh, thank you so much. I hope I can live up to that introduction there. That was exceptionally nice. So a couple of things, being involved in structural heart disease, I think we'll all admit you don't do this alone. You have exceptional teams around you. I've been lucky enough to have a super supportive team at Emory, but as well nationally, being able to be involved with Joan Michaels, Gigi Wyman, who is on the call, being around people who believe that the rising tide rises all boats has truly helped me to continue to look at different ways to make things better for our patients. So, and with that, I'll also give, I don't have a disclosure slide, but my disclosure is that, I'll age myself a little bit, but I loved the show Emergency 51. And Dixie McCall, who was the nurse at Rampart General, was who I wanted to be when I grew up. And what always impressed me was that, she took nursing and she showed how she could coordinate things. She didn't just take orders, and made things better for not only her patients, but the people around her. So again, that will be my disclosure, is that I get to live out being Dixie. So that's a great thing. So our objectives for today are just to talk about the history of sedation for TAVR, determine patients who may benefit from nurse-administered sedation, and identify programmatic benefits seen with the movement to nurse-led sedation. So in 2002, it was super cool. Brittany and Justin were together. I had a rockin' collection of Beanie Babies and the coolest Motorola phone ever. However, in Rouen, this guy, Dr. Alain Cribier, was putting this valve through 22 and 24 French sheets, and the patient was awake. So the idea of conscious sedation in TAVR, or nurse-led sedation in TAVR, is not a new idea. And so the very first case that was ever done of a TAVR was done in Rouen with local and Versed and fentanyl. There was no general anesthesia, there was no TEE, and the anesthesiologist was available, but not in the room. So, how did we at Emory kind of believe in this situation? So again, for us, this is one of my partners. His name is Vasilis Babalieros. And Dr. Babalieros actually went to France and studied under Cribier from 2004 to 2005. And so he was involved in cases 14 through 44. And so for him, he had experience with conscious sedation. And I think what made things really special is that he believed in nursing, he respected what we thought, and really wanted to develop a partnership to see if this was something that we could do. So we worked diligently, and I'll talk a little bit more about how that happened, but we did our first case in May of 2012. Our case was performed in the cath lab. It wasn't performed in the hybrid or the OR. And we used what we called a minimalist approach, which for us was conscious sedation or nurse-led sedation, not MAC. And so when we talk about in our organization what conscious sedation is, we believe that that's to be nurse-led sedation. So in 2012, we worked with our anesthesiologists, and I think that's always the first question that people ask me. Depending on who you hear give this talk, some of my colleagues have said, well, anesthesia didn't want to partner with us, or anesthesia didn't want to do this. That couldn't be further from the truth. Anesthesia was a critical partner in bringing this to fruition. We had lots of meetings with them to talk about ways to keep the patient safe, what they felt comfortable with, what we felt comfortable with. And so in 2012, we had our original patient criteria, and that was number one, patient was confirmed to be eligible by the heart team for a TAVR. And again, at this time in 2012, when this started, it was May, the only patients who were available for commercial implant were inoperable patients. So we started off with inoperable patients. And so the first thing we had to look was did the patient have straightforward vascular access? And at that time, we had a 100-kilogram weight limit. And part of that was just trying to keep the patient safe, being able to make sure we could get to, the iliacs appropriately. And so we had to look at that. And remember, when we said straightforward vascular access in 2012, that pretty much cut out 50% of your patients. Was the patient able to lay flat? And again, the coronary arteries at an acceptable height came later on, because in 2012, we were still using a lot of non-contrast. Were there any barriers to emergent intubation if required? Did the patient have chronic pain that this was going to be uncomfortable for them or squirrely on the table? And were we going to be able to see, where the valve was? And if the answer was no to these, we did them with either general anesthesia in the hybrid OR, and they went to the ICU. And if the answer was yes, they could have conscious sedation, MAC, TTE, we could do the case in the OR or cath lab and send them there where they wanted or where we needed to. And again, in those patients, we had gone through to make sure they were acceptable to be able to have even a shot at nurse-led sedation. So it wasn't something that just one day we walked into the lab and we were like, hey, let's do this. Because again, for us, we were doing cases in the OR. We had perfusion. We had the full OR setup. We had, anesthesia in the room. It was definitely a maximal procedure. And so our first timeline was we actually moved our cases to the cath lab. And then the second thing that we did is we had conscious sedation was administered by the nurse, but anesthesia was in the room. And so they were kind of supervising the process to make sure that things were safe, that there was a comfort level. We knew pitfalls. After each procedure, we would, have a huddle and talk about, kind of debrief about the case. The next thing we did is we moved perfusion out of the room. And then lastly was no anesthesia in the room. And this was about a 3-month process to get from start to finish to where we went from, moving cases to doing our first case completely nurse-led sedation. And so most people want to know, is the minimalist approach even safe? And a lot of people are doing minimalist. This isn't, anything that was necessarily new. So the first thing we did is we looked at it and we studied it. And so in 2014, we put out a paper that looked at what we refer to as the minimalist approach in our cath lab versus the OR with general anesthesia. And again, what we found is that it could be performed safely with minimal morbidity and mortality, with shorter stays and lower resource utilization. And then there was a much larger paper that was put out by Hyman and all that looked at the entire registry. And this was in 2017. And again, for them, they looked at conscious sedation, and it talked about, again, briefer length of stay, 30-day mortality compared to general anesthesia, and stated that the safety of conscious sedation in this population. Now, one thing I really need to point out is there's no standard definition of conscious sedation or a minimalist approach. And so part of that is determining what does your center think. So again, for us, we had to look about why would we even make the change. And so for us, going from this small group to saying, okay, there's a lot of interest around this. At last stop, 70% of TAVR centers in the United States are using some sort of MAC within their program, and 30% are using general anesthesia all the time. And that has changed, obviously, from 90% to 80% and so on and so forth as time moves on. So there's a lot of benefits to doing patients minimalist. And of course, you have improved peri-procedural hemodynamics. There's a reduction in post-procedure delirium, accelerated recovery, decreased procedural times. There's cost savings, and of course, less length of stay. So again, going back to what is minimalist, is it monitored anesthesia? So you have your anesthesiologist giving a little propofol. Is it nurse-led sedation, like what we do? Is it entire programmatic pathway? Is there a post-procedure recovery to being minimalist? And are there fast-track protocols in place? And so for us at Emory, we believe that minimalist is a pathway. And so for these patients, they do get one-day evaluation. So they're getting echoes, CTs, seeing the surgeon, seeing the interventionalist all in the same day, and getting a rapid disposition. Now, again, just to be clear, we have everybody there. However, the patient is also discussed at the heart team, and we can make any changes if needed. But most often that patient is giving a disposition and a date for procedure at their clinic. We admit patients the same day as their procedure. We use nurse-led sedation if possible. They go directly to the telemetry unit post-procedure. If they do have MAC or general, they typically recover in a post-anesthesia care unit for 2 hours, and then go to the floor with a goal of having discharge within 24 hours. So again, this is more than a procedure. It's a nursing care protocol that promotes rapid return to baseline or better, early mobilization, and of course, minimal disruption and deconditioning. And so the main components are, we have objective rules around this now instead of subjective criteria. So built within our order sets are, we have bed rest for 4 hours. That first time the patient gets up, we do orthostatic blood pressures, and we usually ambulate them, most often to the restroom. If they've had any lines, we do take those out. We don't use Foley's, and most often, if anesthesia is in the room, we slave off the femoral. We do focus on hydration, nutrition, and elimination. So there are standard orders in about, infusing the rest of the IV bag, making sure they eat as soon as possible, and any necessarily medications for bowel health. We don't typically give opioid sedatives or hypnotics. And as a matter of fact, we've gone through and taken all of that out of our order sets. If the patient's having that much pain that they need an opioid, we want to be able to have the opportunity to assess them, because that is not what's an expected finding at this point. We have early and ongoing discharge planning. So this discharge begins when the patient comes in through our clinic. And of course, we have the honest conversations with the family and team. We don't want anybody who expects, to have a valve replacement and think they're going to spend a week in the hospital. And then we come in and say, oh no, you're going to go in next day. So there's a lot of level setting that has to occur. There was a trial that looked at minimalist, and this was the 3M trial out of Vancouver that was multidisciplinary, multimodality, but minimalist to next day discharge. And I think what was really interesting about this study, and in full disclosure, we were a participant, it looked at an entire process instead of just a procedure innovation. And so again, what they hoped to have was, improved clinical outcomes, to identify what screening criteria, and that the procedure was matched to the patient needs. There was rapid mobilization and reconditioning, objective discharge criteria, which helped solve a lot of issues for sites around the country, because people would walk in the room and say, oops, should I send this patient home? Maybe just keep them another day, or things like this. And this gave criteria that was specific, to be able to say we can send the patient home, and of course to have a reduced length of stay. And so as you can see here, there was an entire clinical pathway about what happens during the peri-procedural period, the post-procedure, and then again, what is that criteria-driven discharge. And this was something we had been doing since 2012. A lot of our protocols here at Emory were very similar to what was being done in Vancouver. And so again, for us, it was a study that we definitely wanted to be a part of, because again, for us, this was something that we had already been doing. And so I think the interesting thing that was really important is when you looked at the 30-day mortality or stroke, the stroke rates and mortality was very low, but with this plan, 80.1% of patients were able to go home next day. And when they have high, medium, and low, these were the volumes of the hospitals. And so what they found is that there wasn't really a big change in between sites who were high enrollers or low volume centers. The other thing that was really interesting is about 80% of the centers who participated in this trial hadn't used a minimalist pathway before. And so not only did it show success of the pathway, but also just showed that centers, with their support, could be a part of, making this change. So for us, some of the questions were, why do we use nurse-led sedation and not just MAC? And for us, a lot of it was skill task alignment, looking at our skill mix, nurse availability, and anesthesia availability. And so for us, we do have a number of nurses within our cardiac cath lab. Most of our nurses are critically care trained, and so had that experience to be able to give sedation and also, feeling comfortable with the patient. We looked at our processes that were in place, meaning that we were very comfortable giving sedation for interventional cases and certainly sedation in EP cases. We also looked at our other procedure mix of, what other type of cases were we doing? Were we doing, high risk PCI? Were we using, PFO, ASD, MitraClip, and things like this? And we really had to get away from the if it ain't broke, don't fix it mentality. And again, our anesthesia colleagues did a great job. It had nothing to do with poor performance. It just had to do with, how do we move things forward using the staff that we have and just, really tailoring our patients to what that skill mix looks like. So with that, there's always a lot of, going back and forth and looking to say, okay, well, what is that right candidate? And so we did have to kind of reformulate who was our nurse-led sedation candidate. And so eligibility was confirmed by the heart team that the patient was a candidate for a TAVR. And I think what's really interesting now is this was a huge change, meaning that we went from looking for patients who could be a TAVR candidate to kind of assuming everybody was transfemoral candidate for minimalist. Now, if they had alternate access, so they didn't have good femorals, morbidly obese, and we kind of went up to about 110 kilos from the 100 kilos risk of coronary obstruction, any barriers to emergent intubation, did they have intolerable chronic pain, restless during previous caths or unable to follow instructions, or if the patient just says, you know what, I want to be completely knocked out, I don't want to know anything that's going on. We honor that. This is about the patient and transparency. And so if the patient doesn't have any of these issues, then we go ahead and proceed with nurse-led sedation. Now, if they do have any of these issues, that doesn't always mean that the patient is going to get general anesthesia or even MAC. We have a really great anesthesia preoperative clinic, and the anesthesiologist will assess the patient and help make the determination with the patient as to what the right anesthetic is for that patient. So in some cases we use general, in some cases they'll use MAC, and in some cases they will say, you know what, we feel pretty comfortable, this patient can probably be a nurse-led sedation. So it really just emphasizes the partnership between anesthesia and our team. So can nursing give conscious sedation? Well, I don't know all the 50 nurse practice acts, but you do have to look at your state. For Georgia, we have to have protocols, and the nurses have to be properly trained in medication delivery and monitoring of patients. And we do accomplish this, certainly nursing schools, and also we have skills fairs that we do reiterate those trainings and just check off on a yearly basis. And so again, we did pull our Nurse Practice Act, and it talks about, how nurses can give sedation, but they do have to be prescribed by a physician practicing medicine. And so for us, we do have protocols that basically are order sets that have the medications in there. And so we know that pre-procedure, the patient has to have a protocol in place. We have to do patient education, and then also the team has to evaluate. We do have a conscious sedation protocol, and we use this for all of our conscious sedation. We didn't have a protocol specifically for TAVR. So if the patient's getting PCI or EP procedures or PFOs or things like this, we do use the same order set for that. So legally, you have to have an assessment within 24 hours of the procedure. So if you're using an H&P from a clinic visit, the day of the procedure or within 24 hours of the procedure, you do have to document the past medical history, current medications, any history with sedation, and last food or drink intake. We also have to do an assessment, and in Georgia, this has to be performed by the advanced practice provider or the physician. We do have to have a physical assessment, including the airway, cardiovascular, respiratory. We also use a Mallampati score and a physical status evaluation and a review of the diagnostics. And so again, the Mallampati score is looking at, the ease of intubation. And then for the American Society of Anesthesia, it is looking at systemic disease and just making sure the patient would be safe for emergent intubation. In lab, again, in the state of Georgia, the healthcare provider and not the proceduralist should monitor the patient. So again, this is where we have a nurse at the head of the table who their only job is to monitor the patient and deliver medication. There has to be documentation of the level of consciousness. And again, during the procedure for joint commission, the patient for nurse sedation is supposed to be sedate but responsive, and again can be completely alert. Obviously, we don't want unconscious. You have to check at least peripheral oxygenation. You can also do capnography if that's what your site prefers, and then note the pain score. Post-procedure, about 75% of our patients are able to just go directly from the lab to our cardiac telemetry area. About 20% go to our cardiac observation or PACU, and about 5% go to the ICU. Although for a number of months, we have had less than 1% recover in the ICU. So what we did is, of course, you want to examine your results. And, we had been looking at everything all along. I just happen to work with a physician who doesn't like to publish unless you have a really good N. And so we looked at our database of patients from 2012 to 2017. In full disclosure, we do use multiple valve types, but we only included balloon expandable valves in this analysis. We had two groups, those that had nurse-led sedation, which was conscious sedation delivered by the nurse, which was typically fentanyl and Versed, or MAC, which was delivered by anesthesia, and it may be an anesthesia assistant or a CRNA, and those medications could go from propofol, remifentanil, and so forth. So what we looked at is we had 807 patients in the nurse-led sedation group and about 285 in MAC, and our procedure room time was less. The other thing that I think is really important is, there was some concern about why we looked at the echo. And one of the concerns that was brought to us was that maybe we weren't going to pace the patients long enough, or maybe we weren't going to inflate hard enough if the patient was awake, and that was not the case. You can see from these numbers that, the gradients and the aortic valve areas were very similar. So anecdotally, we had a 99.8 decrease in swallowing evaluations from our general anesthesia. We were able to facilitate movement to same-day discharge for highly selected cases. And patients really went back to baseline or better improvement. And this also helped the team. They felt like they were impacted. They participated in the progress. We are a magnet facility, and this was a great story for our magnet applications about how nursing really coordinated with the service line to help develop pathways, to help develop, a change in practice. So that was really important to our success as well. So some of the programmatic benefits that we saw were we were able to improve the quality of care, patient safety, and health service utilization. We do work in a transplant center, and so a number of our cardiac anesthesiologists were able to support other cases. We were able to increase our capacity to be able to get more patients through our system. Our administration was very supportive of the default strategy of minimalist and really helped patients to get to rapid reconditioning and return to baseline. Pre-COVID, having your family in the room instead of having to have ICU and hours and things like this, and having those familiar faces really helped our patients to recover. Again, looking at room utilization, we were able to bypass the ICU for appropriate patients. And even in some areas, recovery areas, we didn't have to use them either. We could go directly to the floor. With that being said, I will tell you in full disclosure that our nursing unit had 4-to-1 ratio. And so we had to be comfortable that that patient would not require a higher level of care than a 4-to-1 nursing ratio could give. And again, we were able to maximize our skill mix. In the state of Georgia, our APPs do not have independent practice. And so we do have an anesthesiologist that is present for induction, but they can manage to CRNAs or anesthesia assistants at a time. And so we were able to maximize their time when we did use either general anesthesia or MAC. And of course, the nurse was already in the procedure for our patients, and so we were able to use them appropriately as well. With this all being said, failing to plan is planning to fail. You have to have your plan Bs, plan C, plan D, so on and so forth. You have to know what's going to happen in emergencies. We did emergency drills. We made sure that everybody was comfortable. We do have a specific anesthesia code for emergent intubation. We also have code blues, so if we need to get everybody in the room, we can do that as well. We do have Impellas and balloon pumps available in the cath lab. We do have ECMO 1 floor away if we should need it, but we don't keep it in the room. We also do have the ability to put patient on pump within 5 minutes, which was the standard that was developed during the partner low risk trial. There is a very specific patient selection criteria that we've been over. So not everybody is a right candidate for this. And then of course you have to look at what your staff skill mix is. If you have a lab that is, 90% travelers at this time, probably not the best time to start with nurse-led sedation. Success begets success. And for us, we moved from a general anesthesia only strategy to MAC for some of our transcaval, axillary, or carotid inappropriate cases. Again, you know, the PACU used to mean that if you had the patient go to PACU, they automatically had to go to ICU. And we were able to work with our hospital system to be able to have the patient recover in PACU and then go to cardiac telemetry. We were able to improve our pathways. We had increased nursing satisfaction and increased patient throughput that we were actually able to do about an extra patient a day just by these time savers and, you know, knowing exactly what the pathway was. Nurse-led sedation is a team sport. You have to have everybody involved. If you have somebody who's a naysayer, it's going to be really difficult. And so again, in our rooms, we have the cardiologist, we have a surgeon, we have the monitor, we have a scrub test, we have a circulator. And this is the interesting thing. One of our circulators is always a nurse, and that's the person who's at the head of the bed. We also have an additional circulator who can do the, who's there for the procedure, can run the pacer, can get any additional equipment, but then after the valve is in, can go and set up the next room. Occasionally we do have anesthesia, but even if they're not in the room, they participate, they're part of our conferences, and they're a part of our review system to make sure that, you know, we continue to move forward. We do have some sort of imaging, either our echo sonographer, if it is a TAVR, or if it is something different that requires like a basilica, we certainly have our structural imager, and then leadership and nursing support. So why do I think we were successful? If anesthesia wasn't brought into this process, I don't think we would have ever been successful. The same thing, I don't think if nursing was involved in the process, just telling people what to do, I don't think we would have been successful. We did have full leadership support to make these process changes because it did impact multiple layers from physicians, nurses, you know, process through our cath lab, equipment, all of this. We did develop a clear process that was easy to follow and was reproducible. And that did take some time. That wasn't like first day we were on the right path. We did have to constantly look and reinvent as need be. And the other piece is reviewing the outcomes and processes to make sure patient safety is paramount and that there was benefit to the system. And so during COVID, how did this help us? Well, we were able to pivot quickly when staff was reassigned. I went back to covering the ICU after 10 years of not being in the ICU. You know, a number of our team members got furloughed. But again, at the end of the day, we were able to continue to move forward because we did have appropriate staff to be able to cover cases. We were able to triage patients and do these cases in the cath lab when our hospital leadership set out like all elective procedures were canceled in the OR. And this also helped us transition to same-day discharge with the same staff and areas. And so again, we did have specific criteria for that, but the recovery for these patients was not unlike what we saw with next-day discharge. So in conclusion, you have to verify the scope of practice in your state Nurse Practice Act. Make sure the nursing competencies are updated. Skill days, education events. We are on the faculty to teach new nurse orientation. We do a number, as a matter of fact, we do 6 in-services a year for our nursing colleagues to make sure that they're up to date, not only on TAVR, but also any of the other structural procedures that we do. And in the proper patient population, nurse-led sedation is a safe and effective method to provide conscious sedation for structural heart cases. And you have to work with your stakeholders to create pathways that work for the patient, your service, and your institution. If you have 20 different pathways, it's hard for people to follow. And you don't want, what we didn't want is we didn't want people taking matters into their own hands about what they thought would be best for the patient. We wanted to make sure that everybody could follow the pathway that we knew was effective. So with that, I say thank you. And thank you so much to invite me to share something that I've been so passionate about. Again, nurse-led sedation has changed a lot over the past almost 10 years. And it's something that we're exceptionally proud of. It's something that we work very diligently with. And I'm happy to take any questions.
Thank you very much, Tricia. This was very thorough, very impressive, especially going back to 2012, where you're doing high-risk patients. To me, I'm blown away as someone who used to work in a cath lab, to say that if that's how we would have started, with nurse-led sedation, wow, that would have been frightening for me to think about that. But the other thing, you must have an impressive staff of nurses, cath lab nurses. And I'm not sure. Go ahead.
No, there's no doubt about that.
I mean, as far as numbers as well as competency, I mean, you must have a lot of numbers. I know in our lab, we had no extra nurses, and we would not, it would have been, we wouldn't have been able to implement this at this, even now, I don't think they have enough nurses to have one nurse totally focused on sedation. That's really awesome.
Mm-hmm. Yeah, no, and kudos to our to the managers of our cath labs and procedural areas, because for this, they, we did work to look at what the staffing had to be. What's very interesting too is, I don't know what the rules are in Michigan, but in Georgia, our EMTs and RCISs are not able to pass medications in the cath lab, and
Same.
so we do have to have nurses who that is their job. And so again, being able to utilize them in that capacity was definitely important to the success. Now, in full disclosure, it's been a little bit more challenging as of recent, with a number of our nurses leaving to do travel assignments. And we don't feel comfortable having our travelers without TAVR experience and extensive TAVR experience participate in that aspect of it. Now, we are very lucky that we do have 2 travelers who we've actually, they used to work for us and now work with us again, just making a lot more money. And so we do feel comfortable because we trained them and they worked with us for years. So again, I think that is, right now, a very specific area that you would have to be very thoughtful of when it comes to rolling out nurse-led sedation.
Right. Yeah, I agree. Anyone else have questions or comments?
This is Annette. I work at Mid-Michigan Medical Center, and I'm sorry I was late for your presentation, but it was very good. And I know I went to the leadership thing with Edwards just a few weeks ago, and it's pretty exciting. I would like to try to implement something like this in our institution. So I have your email. I may be reaching out to you if
Yeah.
I'm just trying to plant the seed at the appropriate time. Right now, obviously, is not the right time.
No.
Staffing's just horrible. They canceled our TAVR cases yesterday. But yeah, I definitely would love to hear more about your stuff, or maybe some of your protocols or pathways that.
Yeah, absolutely. I'm happy to share. And the other thing, I've given my slides, so you all will have access to these slides. And so, feel free to take a look and ask me if there's any questions. I'm happy to help you any way I can.
Thank you.
So looking at your results, I noticed that one of the benefits of nurse-led sedation was decreased contrast volume. Have you thought any why that could possibly be?
Honestly, I think a lot of it was patient preference, or not patient. I think it was physicians who were like, well, we're here, we might as well just take another shot. And so for us, I think it's definitely a more streamlined procedure. The other thing is obviously room turnaround time is much quicker with nurse-led sedation than it is with anesthesia. Just getting the machines in and out, the staffing and things like this. So again, I think everything about it was a little bit more streamlined.
And then I have another question. As a nurse, having worked in the cath lab, annular rupture, do you have do you have like an order set ready? Like if a rupture happens, the nurse should do this, this, and this. Do you have drips already ready to hang? Like when I worked in the cath lab, we had drips ready for STEMI patients, things like that. Like, how does that look?
Yeah, of course. So it's not a, I don't want to say it's a specific order set, but there are protocols in place, meaning that, we do have, you always have epi on the field, you have, we have Lido in the room, ready to go. Honestly, most things, we have the ability to call an anesthesia code, and we do have anesthesia in the same general vicinity. And so they are available to come and intubate within 2 minutes. And so we do have all of those sort of pieces. Now, the other thing is most of your complications, annular rupture is, I don't want to say it's a never event because it happens, but it's rare. But most of your events that happen are things, well, if you have something with the iliacs and a bleed, you typically can manage that in the cath lab until you do get to an OR if it's something that needs a surgical repair. The other piece is that if you have tamponade, you typically can put in a pericardial drain and have that ready. We have the kits in the room just in case, like we would for PCI. And so you can manage those things before you have to get to the ED. So most of your complications can be managed in the cath lab before you get to a part where you actually have to get to the OR. So we do have, drugs ready. For some of our straightforward transfemoral TAVRs, we do type in screen blood. We don't necessarily type in cross, but we do have the ability to have blood shortly. Now, if it's a transcaval case, quite honestly, we do type in cross. So depending on what the case looks like, we may or may not have blood ready in the room as well.
Okay. Awesome. All right. Any other questions? Any other comments? I'm not sure I'm hearing someone. Any comments?
Cheryl?
Yeah.
Can you hear? I'm having a lot of trouble with this connection. I have no chat and I've had to call in separately. So first of all, thanks, Tricia. Fabulous presentation. And I love the way you tied in the early history and was able to so eloquently share how, even back in 2013, when most programs in 2012, in the very early years when we were all doing femoral cut downs, because that's how commercial programs all started, you were already overthinking, saying, we don't need to do that. And there's one observation that I wanted to make about why you were successful. And I think that this is a key learning point for any program that wants to pursue this, is that you had anesthesia and nursing buy-in. Any change that you try and take, you have to have championships, you have to have, the champions, you have to have leaders that believe in it. And so for anybody that's hoping to do this in their own program, it's strategically figuring out who those people are that are going to help make that change. Because to just try and do it on your own, it's not going to work. I know I've talked to our own program about streamlining, because you're always on that journey. Our biggest challenge is that when I did initially talk to our cath lab manager or director at the time, she said, I'd have to redo my staffing model to have an independent nurse just to do sedation. And in these particular times, as you pointed out, we don't have extra nurses. And by actually having our CRNAs in the room, that's eliminated the cath lab from providing that piece. So I was wondering if you have any thoughts or strategies on that. What was your staffing model? Did you need an extra nurse in the cath lab? And what are the arguments I give to say you don't need to do that?
Well, it's honestly, it's kind of interesting. Number one, I think I think this is an option. I think you have to look at your center and figure out what's best. But I think the argument of, well, it really works is probably not always the best argument. The second piece of it is, honestly, we had started making this change because the AORN had actually put together a white paper that talked about nurses who give sedation, their only job should be monitoring the patient. And so there was precedent that was set that wasn't from us, and it was basically the AORN and their recommendations. And so we had started kind of going to that change based on those type of papers. So again, it didn't require a specific skill mix or staffing change for what we did, but it certainly involved incorporating what we knew was being done in other areas of the hospital. Now, the other thing I think it's really interesting that you bring up is that history piece of it. So, I've been honored to be able to give talks on nurse-led sedation at things like ACC or SCI or organizations like this. And what's really funny is I gave a talk at ACC, and I was giving a talk. I was the only non-physician, and it was a bunch of people who use general anesthesia. And this was about in 2018. So it wasn't that long ago, but there was also one panelist from Europe. And so the guys from the United States were giving me a really hard time. And the guy from Europe looked and was like, I don't understand what's so interesting about this, because this is kind of what's done in Europe. So again, it's just what we've made TAVR out to be. Just a maximally invasive in some places, and now just having enough data to be able to say, okay, this might be a viable change, and whether that's moving from general to MAC or MAC to nurse-led sedation. I mean, you have to look at your center, and I think, again, to your point, making sure you have that nursing buy-in and your administration buy-in, and most certainly anesthesia buy-in.
Yeah, excellent. That observation about Europe, they don't have the requirement for a surgeon in the room either.
No.
In fact, there are some places, I know in Germany, there's an institution where the interventional cardiologist and the surgeon don't get along at all, and they are never in conversation. So
right.
It's a very, the environment really does have a lot of impact.
Without a doubt.
They don't have worse outcomes. They don't have worse outcomes.
No.
So you're just fine.
And honestly, up the street from you in Canada, they don't have to have a surgeon in the room. So I think there are some things that are really good about it. I happen to believe in the heart team. I happen to be a firm believer having the surgeon involved and having the interventionalist involved is the right thing. And now that could certainly be because I've worked with really great interventionalists and cardiac surgeons who are truly team members. And so my experience may be not that of every place. So that is a disclosure as well, that I work with people who really work well together. So.
Yeah, that's great. And we saw your team giving live cases at TCT last week. So that was awesome. Yeah, a lot of work. A lot of
stomach pain right there.
Mm-hmm. Yeah. Gigi knows that pain.
Yep.
Yeah. So I want to be cognizant of our time. It's 10 to 12. And so let me ask, did I understand this correctly? You're willing to share your pathways that you've created, your minimalist pathways, or is there a publication we can reference?
The publication you actually have that you included on your invite, and that basically has everything laid out in it. If there are specific questions, feel free to send me an email. I'm happy to answer any specific questions. Whatever I can do to help you be successful or have information.
Okay. All right. I didn't know if, I realize this is nurse-led sedation, but I didn't know if you had a minimalist pathway that you also, is it different or is this the same?
No, it's the same. We really work to streamline it as to not have too many different pathways. And, I'm happy to show our conscious sedation order set. And it's honestly, it's the same for TAVR as it is for PCI. So.
Okay. All right. All right. Anybody else? Any final questions or comments? Gigi?
No, I'm good. I'm good.
Okay.
That was a great presentation.
Okay, awesome.
you.
Yeah,
Thank you so much for the invite. I appreciate it.
Thank you so much for attending. Thank you.
All right. Bye.
Thank you.
Mhm.